Next up will be Bradley Schmitz. Bradley Schmitz is a visiting researcher at the Yuma Center of Excellence for Desert Agriculture. He received his PhD in environmental microbiology from the University of Arizona and previously held two postdoc positions at the National University of Singapore and Johns Hopkins University. Bradley's research focuses on the intersection between water and public health. He has been advising wastewater-based epidemiology studies across the nation since the beginning of the pandemic in 2020. In his current role, he is leading the WBE efforts in Yuma County while working directly with public health officials, city and county administration, hospital staff, and school superintendents to inform local preparedness and response actions to prevent the spread of COVID-19.
All righty. Well, thank you for the introduction. I'll get started, and hopefully you guys can all hear me. But I'm just going to keep rolling through, assuming that you can. And like the introduction just said, a little bit more about me and my team. I am a visiting researcher at the University of Arizona, but very familiar with the state of Arizona. Raised in Arizona since I was 2 years old. Did through high school, elementary school, did my undergraduate and graduate school at the University of Arizona before going to Singapore and Johns Hopkins. But throughout that time, kept really close connections with my roots at the University of Arizona, especially with Ian Pepper at the West Center, who I want to acknowledge, even though he's not listed here. And then also with the Yuma Center of Excellence for Desert Agriculture, also known as WCDA, which I'll mention throughout the talk today. But I want to give special mention to the other members on my team, in particular, Paul Brierly, who's the executive director of WCDA, who really kicked off this WBE project with from schools, and then it transformed into this much larger project. Stephanie Solinsky, who's our director of research at WCDA, and then our team, Sonnet Nelson, Martha Redas, Anna Sanchez, and Shub, who have all been in the laboratory helping us with the administration tasks and really are the heart and soul of this project to keep it running. So just a quick mention of what WCDA is, because it's kind of a unique story. So WCDA was established as a center for research between a public and private partnerships. It was intentionally designed to think of agricultural issues within the state, such as food culture, such as agriculture and food science. And that shifted towards agricultural problems during the COVID-19 pandemic. In particular, one of the major donors for WCDA, who's an owner of a large farm and crop producer in Yuma County, was having trouble with his staff getting COVID-19 and keeping them at work and keeping them health safe. So he made a donation to WCDA asking, is there any technology or process that you guys might be able to help put in place that can help keep my staff safe, and that can at least give us knowledge that we can share with our staff so that they know they can come to work? Because without keeping them at work, we're not only going to have a crisis within the business, but also within the community itself by keeping people employed, but then also a national food crisis, because if the agricultural workers are not able to man the fields and the processes and get the food out on the trucks every single day that get dispersed all across North America, that's food that's not going throughout the supply chain to millions of people every single day. So this became a problem that wasn't just focused within the crops within Yuma County, but branched out to a really national scale. And this project, to give a quick mention, is with Arizona Department of Health Services contract. We are in negotiations to extend this, and I'll explain a little bit of the details kind of as we go through. But for people who are not familiar with wastewater-based epidemiology, I'm going to give a little quick background. My background is as a virologist, and more specifically, virology within water systems. So I focused on wastewater treatment, water treatment, and thinking of ways that we can establish virus removal mechanisms through water systems to ensure that they're not going to be waterborne or eventually foodborne if that water goes towards crops and get people sick. And then that has morphed into, if we know we can measure them in wastewater, them meaning any microbe, if we know we can measure microbes in wastewater, why can't we use that to see what's happening within the community on an epidemiological scale? So I'll talk about how that shifts within COVID-19. And within the pandemic, I think most people are aware that we've had several peaks of COVID-19 cases throughout the last 18, almost coming up 24 months. And throughout these peaks, we're only really getting a good measurement of those that are clinical, right? Those that are coming in and reporting themselves as symptomatic. Sometimes we get good cases, but asymptomatic. But these peaks are this peak that I'm showing here, which is our world in data, COVID-19 within the United States, is really the 7-day rolling average of those only that reported infection. And then we can utilize that information and go county by county and say, okay, maybe these areas in the United States are more hotspots than other, but that can be deceiving as well because some parts of the country have a higher reporting percentage than others, right? So we're even though we're seeing that their cases might be high, we're designating that as a hotspot. Whereas we've also seen contradictory reports wastewater throughout the entire country that we could argue gives a better coverage of all of the cases within those communities because it's incorporating both the reported and reported individuals. And so that's where the WBE tries to come in and overcome some of these limitations with the clinical. And I mentioned some of them. In the early stage of the pandemic, and by early, I mean February through June of 2020, right? When most of us were in our homes, not going outside and really didn't have a lot of knowledge on how this disease was really spreading. And we were in lockdown, essentially quarantines. Well, there was limited tests available at that time as well. So even though people were reporting, or trying to report, they weren't having access to those COVID-19 resources and couldn't report themselves. So in some cases, we saw in wastewater really, really high levels of SARS-CoV-2 RNA, although we saw really low levels on the clinical data. So we were trying those up. And then as we started to shift, we started to see there's a lot of false negatives and false positives with COVID-19 tests. And over the evolution of these tests, and as they become better, we start to see data align a little bit better between clinical and wastewater data. But the main part that I want to really harp on right now is the unreported cases, right? So there's asymptomatic individuals that would really never know that they were sick, or shouldn't say sick, that they were ever infected and that they could be potentially transmitting to other individuals unless they got tested. And if they don't have symptoms, why would they get tested? And also there's people with very low symptoms or were mixing up their symptoms with allergies or the flu, or just really weren't motivated to go get tested. So there's a lot of lack in understanding throughout these stages of the pandemic about what we're actually seeing from the clinical side. And then we go back and saw what there's lags in reporting cases. How do we line up the number of deaths to wastewater? And then really, how are we going to measure the reoccurrence of infection, especially as we start to see breakthroughs, cases with the vaccines, new variants, and how long-term immunity is going to be affected with vaccinations? How are we going to see dynamic shift if we're relying just on clinical data, although people are reporting less clinical data? What is that really telling us? Well, and we also did a report with the University of Arizona between wastewater and clinical test, which I'll talk details about. That we found that within a young population living in the dormitories, just under 80% of individuals that were infected with SARS-CoV-2 were asymptomatic. So that showed a very, very high proportion of individuals that would have not been accounted for in these clinical tests. And those were individuals that the University of Arizona otherwise would not have known were spreading across the campus and would not have known where to allocate their resources for response action or preparedness actions to prevent further transmission. The CDC also, up until I think this went through May of this year, reported that only 1 in 4.3 cases of COVID-19 infections had been reported. So again, two very high, and that's across all demographics. And so again, that's showing a very high proportion of individuals that are not being accounted for necessarily. And that goes back to the county data that I was talking about, right? We try to pinpoint where we're seeing certain increases in certain areas. Well, that's very dependent upon what is being reported and who's reporting and what's going on within that community. So you have to take not just a clinical perspective, but you have to start to collaborate with individuals, in your citizens, through the hospitals, through major businesses, to really get a better idea of who's reporting, why they're reporting, what's happening in the community that would make people motivated to report, or what's happening in the community that would cause further infections or transmission. So are there major sporting events where large groups are coming together or not? And trying to piece together the clinical data along with wastewater data is kind of what I'll go through as we get through this presentation. But to overcome those limitations in the clinical, how can we measure COVID-19, including the reported and unreported? And that's where we came up with the phrase that poop never lies, right? So in theory, if somebody's infected with SARS-CoV-2, they should, in theory, be shedding RNA through their feces. Now, before I move on, I want to take one quick tangent and say that there's been some reports that have said only 50% of infected patients have been shedding in their feces. We did a sensitivity analysis on all of our publications between doing 50% and 100% of individuals that are infected shedding, and we have no statistical significance at all in any of our data if it's only 50% or 100%. So as I go through this presentation, there's a caveat. So even though there are some reports, we have done several sensitivity analysis that show that report actually does not influence our results at the end of the day. But as I mentioned, several reports, and this is just 4 of the most popular and highest cited, have reported that individuals that are experiencing symptoms and also individuals who are asymptomatic can shed SARS-CoV-2 RNA in feces, usually after 24 hours of being infected, and peak shedding persists up to about 6 days after infection. And then from the onset of symptoms for the next 25 days up to a maximum of 33 to 35 days, there's an exponential decrease in the amount of RNA that's being shed by those infected individuals. Now, what does that tell us? That tells us that if we focus in on one wastewater sample, that means everything that we measured from that day is most likely from new infections, new people being infected within 1 to 6 days. And we can utilize that information to give an estimation of what's happening in the future, because typically they're shedding within 24 hours to 4 days, and then starting symptoms 4 to 6 days later. At least that's how it started, as doing very changing. But that's where the WBE is showing us is the trends from those individuals that are infected. We can see it in the wastewater about 2 to 4 days prior to them showing symptoms. So how do we actually conduct WBE? Well, you break down your communities into knowing what your we call defined demographics or defined communities are going to be. So you can look within wastewater areas, specific buildings. You can look within pump stations, if anyone understands what that means. But you can take a GIS map of the entire service area of the wastewater of a wastewater facility, and where there are pump stations, basically little stations throughout the community that pump the wastewater to that main facility, or individual manholes, and break apart your community in certain sections. And that could say, okay, in the northeast region of this manhole, we can collect this sample, and that sample of wastewater is going to be specific for these 20,000 people. If we take a sample from a manhole in the southwest region, that's going to be specific for these 10,000 people. You can break apart your very, very large populations of several million in instances around the US into really, really small communities. What that does at the end of the day gives you more finite information to where you can allocate resources and be more targeted in your response actions, which I'll get to in a little bit of how we're doing that. But to get that far, we have to collect the wastewater from those manholes that we identified from that service area. We take those samples and concentrate them immediately. So usually our samples are collected during the peak flow hour of that specific manhole, lift station, or facility. Why the peak? So there's reports between peak versus composite. If we do composite samples, we could be diluting. We found that we can be diluting our sample throughout other hours of the day where there's not as much activity. Basically, activity meaning there's not as many people flushing the toilet after going poop. But in certain hours of the day, there's also increases in industrial waste, storm runoff, just general waste that is not synonymous with human waste that can dilute your sample. So if you're focusing on the peak hour, where it's your peak population, typically in the morning hours, and then right after work, where people will take a shower, go to the bathroom, go through their daily routine for hygiene, you can focus in on when you could probably get the best representative sample for your population. Well, we take that during the peak hour, we take it to our lab, immediately do a virus concentration. Then what we're doing there is removing all the wastewater, getting just our virus, doing a viral RNA extraction, and then doing quantitative or digital PCR. And we do all of this within really a 6-hour period. From the time that the sample is collected to the time that we have a PCR result is a maximum of 12 hours, but on average, we're doing it within 6 hours. So very, very rapid turnaround to be as real time as we possibly can. And then what do we do with PCR? We're using the CDC targets for N1 and N2. But we started even doing N3, but we've refocused our targets to look at just the N1 gene. So when we look at what we're seeing in wastewater versus clinical cases, the N1 is really only give us the best representative samples of what's happening in the community. So now we're focusing just on the N1. We've also worked with the WHO target, the Chinese CDC, and several other targets for variants as well. But for now, for this presentation, we're focusing in on the N1 gene from the capsid. So why does wastewater surveillance have some benefits? Well, I mentioned that people that are infected can shed prior to showing symptoms. So it's a little bit of an early identification system. You can potentially get samples processed within 6 hours, know what conditions are, and if they've increased or decreased from your samples previously, that can give you an early warning of what you might expect within that certain designated area of your community, whether clinical cases are going to increase or decrease in the next few days. And we do collect samples every 3 days and to try to constantly be ahead of the 4 to 6 day period when individuals will start to show symptoms. It's also the pool testing approach. So as I mentioned, wastewater, mostly everybody has to use the bathroom. I think everyone does. And so the community testing will get everyone in that sample, or mostly everyone in that community within that peak shedding time. And then it's a better idea of actual conditions. So you're not subject to the same variables for limitations as you are with the clinical data. It's actual conditions that are happening today of everyone. And then you can utilize this information to inform public health officials and use that to create targeted response and preparedness actions, which is essentially what we're doing in Yuma, and I'll get to it. But before I move forward on the actual process of what's happening, there's a story within the University of Arizona dorms. So throughout my PhD, 10 plus years ago, we developed a library, basically a list of microbial targets that we want to be able to test throughout the Tucson community in order to understand what epidemiological trends and diseases are spreading at certain times of year through seasonality. We also had already identified what manholes would be specific if there were ever to be a pandemic or an outbreak on the university campus. So we've had this prepared response ready to go for several years. And so when the pandemic started, I got back in touch with Ian Pepper, who was my advisor through my PhD, and coordinated with him and said, Ian, are you going to be doing this dormitory study from everything we've established? And at the same time, through just connections that I have now in the wastewater world, we are also sampling wastewater from communities that range from just a few hundred to several million people throughout the US, over 50 different municipalities across the US and in all different states. And we are going to compare on different scales what wastewater could tell us. And what we found was the dorm study was actually the best study out there that we could even look into because of how defined the communities were. We knew exactly the number of people in each building, and we knew exactly the peak flow, how many people would be infected. We knew the demographics, age groups, race, gender, everything. Well, what we did is we decided, okay, that's going to be the best representative population that we can look at, or I shouldn't say representative, the best controlled population that we can look at to try to answer some of our main questions for WBE. So we came up with a study with support from the University of Arizona, where every individual coming into the dormitories had to test negative twice by antigen and PCR test before they entered the dorms. What that did is it made sure that we knew everyone coming in theory, was not going to be carrying virus. And so we knew that we were starting off with a controlled negative population. At the same time, that first week as students were moving in, we tested the wastewater every single day from each of those specific buildings. And there's 13 buildings, and all wastewater samples were negative. So for the week before classes started, and before there's a lot of transmission from classes starting, we knew that we had nobody that was positive, or at least nobody tested positive, could be carrying, but at least was not reported or tested positive for COVID-19. And the wastewater was synonymous with the results. Then classes started, and within 48 hours of classes starting, depending on which building we were looking at, we got our first hits of SARS-CoV-2 RNA being positive. And to give context, for us, it did not matter what the concentration of the target was. We used it as a presence absence. If the virus RNA was positive, we treated that as a positive. We didn't want to look at how many people or that. We said that's an automatic trigger to go in and test every single individual. As soon as we did that, within the first dorm, we identified 2 people that were asymptomatic and had just been exposed to COVID-19 and had not yet tested positive. Then they were tested that same exact day, and they tested positive. And so wastewater was able to give an early indication of asymptomatic individuals prior to them showing symptoms, that they could be identified and removed from the community before they could transmit and spread the disease further. At the same time, one individual from that community had just that day started to feel symptoms, went to a testing site themselves, reported as positive, was also moved into an isolation facility. Once we removed all the people that were identified as positive, that within 24 hours, that wastewater sample returned to negative. Actually, I have it broken down here. Sorry, I forgot to move the slide. The wastewater returned back to negative and stayed negative, and then a person who had returned from isolation prior to the university opening came back and also showed negative in the wastewater. So in theory, we knew as we were moving people throughout the campus community, we were able to control when, or give an early indication of when they would test positive and when they could return back to the dorm and not be shedding in their feces. And we make the assumption if they're not shedding in their feces, they're likely not shedding respiratorily as well, because there's several clinical reports out there showing that fecal shedding of SARS-CoV-2 RNA persists much longer than respiratory positive samples would affect it. After we removed all those individuals, for then on, all wastewater samples were negative. And this breakdown and how we conducted it and all of the results has been published. And up through the end of that first semester, there was 91 instances of early detection of asymptomatic and symptomatic individuals that we were able to remove from the facility where they reported, and in theory stopped 91 or averted 91 outbreaks of COVID-19 in the community. So we took that format and decided, okay, if that was such a success, how can we take this really defined community concept and try to make that on a larger scale? And that's where Yuma WBE comes in. And this is where the University of Arizona West Center flows in with WBE. So at this time, the University Dormitory Study was showing success, hadn't been published yet, was showing a lot of success, was starting to be reported in a lot of international journals and newspapers. And that's when the donation from the farmers in Yuma reached out to WBE and said, we've heard of some technologies that are out there that can help our workforce stay safe and to keep our keep our production up. Is there something you can do? And that's where the team really came together. So the objective of the Yuma project really is to create a pilot study for identifying COVID-19 cases, or at least increasing prevalence within specific communities, in order to allow targeted response actions that could focus public health resources into those susceptible communities, rather than doing everything across the community at one time. Could you be more targeted, more focused, and have a better impact, and really essentially save money and effort at the same time by being able to be focused with your resources? So we took that defined community model and we broke it across. The map on the right shows a breakdown of the 5 municipalities within Yuma County that we are sampling. And the idea is that we are able to identify the light pink shows the service area of the wastewater facility, and the borders show where we cut off the communities between those service areas. So if you look at North Yuma versus Midtown versus Desert Dunes, although those are all within the city of Yuma, we were able to break up the entire city into sections where we could define the wastewater specific to those exact communities. So if we see wastewater increasing in Midtown, we know that it's synonymous with those clinical cases within that region that you're seeing on that map. And so within each of these as well, there is one wastewater facility, pumping station, and or manhole that could be specific to each of these communities. And we sample those twice a week and utilize that as our early indication for wastewater. So following the same model as the dormitory, but on a much larger scale. And so here's a sample breakdown of the different municipalities. So there's 5 municipalities, but we have 12 sample sites here, but then also we have 13. We also now are doing samples from targeted buildings. There was as a side tangent, there was a recent outbreak within the detention center within Yuma. So we've been now sampling twice a week within the detention center and utilizing the dormitory model to inform that facility of when they might need to do clinical testing of all the inmates and all the employees in order to possibly segregate into one wing of the detention center those that are infected versus those that are not. And you can see here on this map, as we broke down the communities, there's a wide scale. So anywhere from 500 to over 20,000 people. And interestingly enough, I can say now, I'm not going to talk too much in the presentation, we can say that we've been able to optimize our processes specific to the scale, so the number of people within the population. And by looking at the different populations, we've been able to come up with this flow chart of how we do our process. So on day 1, we collect, which is every Monday and Thursday, we collect wastewater samples, we process them through the process I mentioned earlier, and we report those results the day of, or what's typically the next day after we want to do an extra QA/QC on the sample to ensure what we're seeing. We report those results to the individual municipalities, the local public health officials, and any key stakeholders that would find that information necessary to protect their residents, employees, whatever it is. That data then works along with the public health officials. So if there is an increasing trend or a level of concern, which I'll mention in a minute, we've been able to break the concentrations down specifically to each community to know what level of concern would show a drastic increase within the community, which would be an indicator that disease transmission is at a level that is currently not controlled and will continue to increase, but also at a stage where if you implemented response actions now, you might be able to bring it down. So within the report, we coordinate the local public health officials with the municipality jurisdiction representatives, and they coordinate amongst themselves to see what clinical testing, vaccination, public outreach might be necessary to help bring that down. And these are the levels of concern that I mentioned. So this table is really one of the first of its kind. I've worked over 100 different wastewater WBE COVID-19 projects in the US, and this is the first one that I know has been developed and working and instituted. So this process is kind of leading the way in a sense. But what we've been able to do, and this is specific to just Yuma County, we've created response actions and levels of concern specific to different communities. But within Yuma County, what I'm showing is if there's non-detect, we show level of concern 0, which shows that no response action is needed. However, a non-detect sample for us and level of concern 0, we typically never report that. We usually say if it's non-detect, this sample was keep the last level of concern intact until we have multiple samples back-to-back consecutively that show non-detect, and then we can at least put it at a level of concern 1 because we're still seeing clinical cases. If concentrations go anywhere between 1 and 3 logs, we keep that level of concern 1, which throughout 2020 and early 2021 has been really correlating with just enhanced awareness to where if we were just putting a mask mandate, that we would not see a large increase in clinical cases. But if concentrations get above 4 logs and within 6 logs, we typically recommend clinical testing because that's at a concentration that would be synonymous with a high current transmission of disease. And if you were able to bring in a response action at that point, you might be able to prevent further spread. And anything over 6 logs has been synonymous really with uncontrollable transmission and typically shows very, very high increases in clinical cases. I'll mention that these response actions are just advisory. The farthest column is just what we put together when cases were at their peak in Yuma County in December, January, and February of 2020 and 2021. If we wanted to keep the most conservative approach that we possibly can, so we're keeping these ones intact. However, if we were to look at this now, we could probably decrease the response actions, but keep the same level of concentrations in place. And we report these also weekly to us. So even though we're reporting the results directly to the public health officials and the city administrators for them to coordinate and put in the right public health actions, we do weekly report to a much larger group that's helping us, that's advising us on what's happening within the community. Was there a sporting event? Was there a community fair or county fair? Was school back in session? Was a new mask mandate put in one employer that we didn't know of? So we're trying to gather as much information about the community as we possibly can to understand what our results are showing on the wastewater side. So we report weekly updates to this steering committee that incorporates a wider range of people, and at the same time, they provide us feedback as we go along. So I want to show a little bit of results. And so when we look at the level of detection here, and we look at this, what looks like scattered results back and forth, I want to turn your attention to really from August 2nd to current date, the end of August. If you look within that range, it looks like there's a lot of up and down. But if we go back to our levels of concern, they're staying within the same level of concern the whole time. So we've stayed at a level of concern 2. That is one of the major reasons why we decided to have it be a 2 log range, because we saw, even though we might have a 1 to 2 log fluctuation within our wastewater sample, we're not seeing as massive fluctuation within the clinical reporting. So we wanted to give ourselves a little bit of a buffer that says, okay, as long as we're within this little bit of a variation within wastewater, which could be due to the PCR itself, the sample collection method, who ran the sample, how long was it on ice. There's too many variables within the wastewater collection system itself or process itself that we needed to have at least a little bit of a range. But this has almost worked perfectly. Just having a little bit of range there has been, and keeping it within a level of concern reporting rather within a large range has been really, really well for really two main reasons. One, it provides us a conservative approach to keeping response actions in place. That way we're not constantly shifting what's in place day to day, and we can be really focused within our mechanisms for targeted response actions. And second, it's a lot easier to report public if somebody has a question what a level of concern 2 is and what response action goes a level of concern 2 is, than saying, yeah, there was 4.4 log 10 genome copies per liter of SARS-CoV-2 RNA detected on the 9th, but 5.4 log 10, right? So we really wanted to break this down in thinking about in the future, we're going to have public facing aspects to this that we need to be able to break down into a simplistic form that we can tell the public, look, even though the concentrations are high now, you in theory do not need to overworry. Here's the response action that you should take in place yourself to feel comfortable with going about your daily life. Same thing here. You'll see that there's a lot of peaks, but I want to focus your attention close to September 16th. And you'll see that we did reach above 6 logs there. So we have reached a level of concern 6. Now this population, I'm not telling you which one it is, but I will tell you this is a very, very small population, one of our smallest ones. Within small populations, there's a lot higher chance or opportunity for the wastewater concentration to be more variable and fluctuate more. And that's because you have less mixing and it's more sensitive to one peak shedder, right? So one or super shedder or whatever you want to call it. One individual that might be brand new to infection at their peak shedding and just at this exact time that we collected that sample, their feces was able to be collected. Whereas if we're looking at a larger community, those peak shedders are usually diluted out by a much larger number of non-shedders or non-infected individuals, so it can be much more consistent. But even within that fluctuation, we've been able to stay right around the same level of concern, keep the same response actions in place, and try to be as effective as we can. And so how do we interpret these results? So I do every Monday and Thursday with the results that we get, I do have a spreadsheet that I send to the public health representatives and the jurisdictional representatives to say what's happening. But to break it down with them, we came up with just simple language in an email. And this is exactly what the email looks like. It says, good afternoon, one line for what the samples look for. And then for that specific municipality, we list the 3 sample locations we have. And we have about 5 or 6 specific sentences that relate to what is happening and being interpreted in that sample for what's happening within the entire community. Now, it's not these interpretations are not just based on what the concentration in the wastewater are. They're also subjected to what's happening within the community. So again, sporting events, in the beginning, we had targeted clinical testing. So we knew, okay, we might get high numbers of clinical reports because we encouraged the public to go get tested. And we did, we saw a slight increase. Whereas if we didn't do that, we probably wouldn't see it. So how does that relate our level of concern? Even though we're reporting a high clinical level, we're not seeing it in the wastewater, so we're not going to increase that level of concern. So you can kind of work your clinical data with your wastewater data to have a better understanding of what's happening within your community. So we report that out to what we call our local surveillance and response teams. Those individuals that would be specific to those areas that are being sampled. And then we also have a weekly steering committee update where throughout, for all of the samples, we summarize them to the 5 municipalities. And we show a decreasing trend, steady trend, or increasing trend. A decreasing, in order to change in any one of those 3 categories, they have to be changing within a level of concern. So then essentially there has to be at least a 2 log change in the virus concentration in the wastewater sample in order for us to feel comfortable that there is enough of a change to change the response actions that are currently set in place. And then we also report what the level of concern is. So even though it's steady or increasing, what is it increasing to? Or even if it's decreasing, what if it just decreased from a level of concern 3 to a level of concern 2? We try to be explicit as we can, while also keeping this as simplistic as it possibly can be for somebody to read who's not as familiar with wastewater testing. And so what is this actually reported out to? So we show all this information. What is it actually done? Well, in early February, that we did about 2 weeks worth of baseline testing to get an understanding of what we need to do to optimize our samples. And a week after baseline, we got our first very large concentration peak within the wastewater. And we worked with the Yuma County government to release a public statement to all of the residents throughout Yuma County, and which is here. This is it, word for word. Took it from their Facebook. They put it on Facebook, and they also released it in papers and other outlets. And you'll notice that through here we said wastewater. The biggest thing we've learned from public outreach is people don't understand the difference between water and wastewater. Water is what can be consumed, and wastewater is technically your feces and your sewage. So now we've changed all of our public-facing outreach to say sewage rather than wastewater. But the main point of this is once we got our first hit, we knew exactly the neighborhood that was showing high concentrations. Associated with this Facebook was also a map of the exact location that was showing high. And we informed individuals, if you've been in that location, know anyone that lives in the location, or come in contact with anyone, that you get tested or be wary that you might have been exposed, since we're seeing that in the concentration. And that there are clinical testing sites available to you. And we listed the 15 sites that are available in case people wanted to get tested. And then as we saw concentrations decrease and we saw clinical numbers decrease from that area, we also reported the decreased level of concern to let people know that that alert has come down. They don't have to still be worried about that area. This happened about 2 weeks later. So we report when it goes high, and we also report when it comes back down to lower levels so the public can be aware. We also utilize this information to promote vaccination. So in certain areas that we knew were more had a higher unvaccinated rate than other portions that were also showing high concentrations within the wastewater, we utilized wastewater information that a lot of the county had started to accept and started to see and hear about for several months. Utilize that as information that could be utilized to maybe promote vaccinations as well. I don't know what the actual results of the vaccination were, but I do remember at the time that we released it, vaccination was about in the 40 percentile, and now it's about 60. I think we're getting close to 70% within Yuma County. Also within the border community in San Luis, which has actually been shown to be our most susceptible because it is the border community, and there's a lot of easier transmission from unhygienic conditions coming across the border. People are constantly moving, and that population is very transient across the border on a daily basis. We do see wastewater concentrations stay high, but they typically are still giving a really good indication of increased clinical tests increased clinical cases. So we utilized that information, informed the city mayor, and the city mayor decided to put in a mask mandate for all people living and working within certain facilities, starting at an effective date. And I believe that mask mandate has stayed in to this day. We also utilize it as a newspaper. We put together a newspaper article with the local newspaper to announce targeted testing for wastewater. So if anyone was interested, such as other farm communities that would want to have similar capabilities as they did with the dormitory, that we could do that, but also to inform people that we were going to be doing target testing at specific communities in the area. And then here, I won't play it because I think I'm getting close to time. We did also appear in the local news channel twice. So trying to hit every avenue we can to make the public aware of what concentrations we're seeing. So we have Facebook, local websites, public health websites, county websites, again, newspapers and the local news channels. And now this has spread on to day pack facilities. So instead of doing just community-wide, we're also doing facility-specific, very similar to what we're doing within the dormitories. And what we've shown here is we've had 2 events where we're able to identify 4 and 1 asymptomatic carriers within this agricultural facility. Before they showed symptoms, remove those, the wastewater again returned to negative, giving us indication that we had identified all individuals. And then we're able to keep that workforce healthy, and that facility was able to stay open without having to worry whether there was going to be an outbreak. And then also we've incorporated, just recently, the last couple of weeks, we've incorporated variant testing across all of our samples in collaboration with TGen, which we're very excited about, especially as we move forward with the pandemic, as variants are continuing to arise and the virus continues to adapt. We're going to have technology in place that will let us be ahead of when we may be able to see those, especially because we are sampling right across the border. And we are working now with representatives on the Mexico side of the border to get some of the wastewater samples, so we could potentially be measuring whether variants are developing within Mexico or could potentially enter the United States through the border. And then lastly, I mentioned we're utilizing this information not just for public health action, but also public health research. And through our different demographics, now this graph is showing 2 communities from Yuma. We're still waiting on results for a community Yuma that is median age over 60. And we're really hoping that we can get that data from ADHS to share the number of reported clinical cases per day. We can utilize that information in tandem with our wastewater to get fecal shedding rates of different individuals. And across, we have now 8 communities, this one's showing 5 or 6, what the median shedding rate is. And what we're seeing is as you increase age, your fecal shedding rate increases. But also what that does is show that the fecal shedding rate can be very specific to each community and based off of demographics. And you can utilize that information in order to create models and calculations to estimate the exact number of infected individuals in your community, which we have done. And that is the first draft of manuscript is completely finished, and we're hoping to have it submitted for publication in the next 2 weeks. So very excited to show that and start to actually develop models that can give exact numbers for public health officials. And I'll summarize everything by saying this pilot project in coordination with the steering committee has shown massive success for wastewater to inform public health response actions and to inform the public of what's happening and preventing and averting outbreaks. It's much harder to show the actual outbreak aversion within the large scale community, but if we break it down to each of the individual facilities, we have a very strong track record now showing of how we're able to actually avert individual outbreaks. Typically too, I didn't show the graphic because there's too much data on it. I didn't want to get sidetracked, but typically the wastewater is correlating very, very well with the clinical data as well. So essentially, if we're seeing increases or decreases in the wastewater, we see the same increase or decrease within a week within the new cases of reported infection. And lastly, the economic impact, which I didn't get to talk too much about, but there's been large impact towards local businesses. The University of Arizona advertised that they had success with WBE, that they were remaining open, and their enrollment went up 400%, so which had a huge economic impact and influence for the university. Also, I mentioned DatePack able to keep the business open and avert outbreak and really food shortage. And then lastly, it's a much more cost-effective and widespread community model than looking at individual cases. So you can be proactive by looking at your entire community as a pooled sample rather than having to rely on clinical tests for each individual.
Thank you, Bradley.